Cornea session 1. We are expecting some more panelists for good discussions, and I thank all the presenters and the audience who have come here to listen to the series of talk, which is very interesting according to me. Let me first call upon Dr. Ashmita, who will be talking to us on the telltale signs to suspect viral keratitis.
Good afternoon, everyone. Thank AIOS Scientific Committee for this opportunity. Small gatherings are always more interesting to discuss, and we can go into the details. We have all the time, looks like. So when we think of viral keratitis, it could be any virus which affects the cornea and the anterior segment, but the most common is a herpetic group of virus, of which herpes zoster is something we all have seen and know how to manage. It comes with more obvious signs. So we will be discussing about herpes simplex virus keratitis, which can present in any of these forms. It could be an active virus replication or an immune reaction to the virus particle or the virus which is in the ganglion. Now, why is it important to diagnose or suspect viral keratitis? Unfortunately, in our country, there is a blanket therapy for corneal ulcers, which includes antibacterial, antifungal, sometimes even antiviral topical. But what is important is here the role of steroids in treating viral keratitis. As we know, and in bacterial ulcer, sometimes we might add steroids. Fungal is an absolute no-no, but in viral, it is an absolute yes, and it forms a mainstay of the treatment in managing in addition to the antiviral. Also, if we do not suspect a viral keratitis, even if it's an inactive state and we operate on the patient, do a cataract surgery or any form of surgery without an antiviral cover, it can bounce back really bad to the surgeon and cause significant worsening of the corneal problem. Another differentiating feature is it is very difficult to diagnose because we do not have a very sensitive microbiological workup like in bacteria and fungus. We scrape, send to the lab, whatever comes we treat accordingly. It's not the case in viral keratitis, so it is a clinical diagnosis in most of the cases. Also, accessibility to PCR and the tests for routine OPD case or in a small practice is difficult and challenging. So when we say viral keratitis, dendrite is a very obvious sign and we all have seen and managed, but an early dendrite or a small peripheral dendrite can easily be missed. Like in this case, you have a gross overview, you find the cornea normal. When you look at this localized redness, you know that there is something there. Only when you stain, you highlight and you see the dendrite. Here I would like to describe what I call as a shadow sign. So if there is anything on the cornea, be it a small foreign body, a tiny epithelial defect, epithelial disturbance or a dendrite, when you put a light on it in an indirect illumination, a shadow of its pattern falls on the iris. There are a lot of times when in a busy OPD you're just seeing and then you see a shadow on the iris and then you defocus, come back to the cornea and you find something on the cornea. Like here you're seeing the shadow of that pattern of the dendrite on the iris, which comes out beautifully on staining. Now the next and a very common and underdiagnosed in non-cornea practicing ophthalmologist is a stromal or immune HSV keratitis. It has a very typical edema that it presents with, what we call as pot belly edema. So the other causes of edema when we see, be it toxic endothelitis, we see an anterior stromal bulge and the thickening in the stroma, but in viral keratitis you will also see a bulge in the posterior stroma, what is called as a pot belly edema, like we see in these cases. Now when you see a localized edema in a cornea with no infiltrate in the cornea, staining is negative, you should have a high index of suspicion for a viral keratitis. There is a very clear-cut demarcation between the stromal, the edematous part and the normal cornea. When we talk about HSV endothelitis, It presents in the form of disciform edema, a very circular, round-shaped corneal edema. Again, no stromal infiltrate. I'm talking about pure endothelitis. No infiltrate in the cornea, no staining on the cornea, and clear-cut demarcation between the edematous area and the clear area. But at the same time, be very cautious in labeling as viral and adding steroids. If you see any form of some amount of infiltrate on the cornea, there's no harm in doing a microbiological workup, ruling out bacteria, fungus, and then starting the patient on steroids and antiviral. History of recurrence. So when you suspect viral keratitis, always ask the patient if there has been previous episodes. If you ask the patient, okay, has there been any redness in the past? Sometimes you'll just wave it off without, unless you ask into the details. They very commonly say, when it's hot, I sometimes get redness, but not significant, just passes away. When I'm sick, when I get fever, sometimes I get redness, but not like this. So they deny the recurrence, but you know that when they're saying there have been recurrences during illness and during febrile episodes, it could have been a viral, and this is indicating more towards the diagnosis of viral keratitis. Now, rapid melting of cornea. Unlike in cases of bacterial or fungal, where it is the late stage of the disease where the corneal thinning starts and then it perforates, melts and perforates. But in viral keratitis, it does not correlate to the extent of the lesion, but you might see a thinning and perforation very rapidly in the early stage. Now, if any patient of corneal opacity comes with a deep vessel like that, it may be in an inactive state. But as I said, if you see deep vessels like this, be alert. No harm in starting antivirals, especially in the perioperative period if you're undertaking the patient for a surgery. Now, this is what we call as HSV footprints, where there have been multiple recurrences and there have been scarring. So this is how it will typically look. If there has been an old bacterial keratitis or fungal keratitis, you will see one uniform large scar maybe, but here you will see irregular scarring of the cornea. At some regions it is thick, at some areas it is translucent, somewhere there is thinning. So that irregularity in the cornea along with these opacities are different levels. Again, point towards viral keratitis. If there is any of these stromal sign with active uveitis, AC cells and keratic precipitates, it could be keratouveitis, and that is when you need, in such cases if you see AC cells, uveitis, start on steroids without antiviral cover. It will initially respond but then worsen later. Sometimes it can masquerade as a case of PUK and then turn out to be viral keratitis. Necrotizing viral is difficult to diagnose, difficult to manage, but if we suspect and start antiviral and steroids in an early stage, we can salvage the vision and the eye. So like this case where I said you see an early melting and perforation in the stage of the disease. Now, when is it not viral? So if you see an epithelial defect which looks like a geographical ulcer and you're not sure whether it is viral or not, always stain with a rose bengal, and so this is not viral. But a raised margins, and when you stain with rose bengal, it will be a double staining, only the edges will take the rose bengal and the base will be stained by fluorescent. This is viral. Again, I said when it is localized edema, it points out to viral, but always rule out the other causes of localized edema, like rule out a Descemet's detachment or rule out an absent Descemet membrane, like in this case. So this edema which I said, this is not that typical pot belly edema or a localized edema. It is a diffused edema, and this is not a viral stromal keratitis. So summarizing, always stain so that you do not miss a dendrite. Pot belly edema, localized stromal edema suggests immune keratitis. Disciform edema, disc-shaped characteristic of endothelitis. Beware of deep vessels and HSV footprints, and it may warrant a perioperative antiviral cover. Necrotizing viral keratitis difficult to manage. Be nice and kind to the patient because it is a recurring problem. Please explain to them. It always happens if you do not tell them it is a recurring problem, they will go to the other doctor next door कि पिछली बार किया था ठीक हुआ वापस आ गया. So you need to tell them that this is a recurring problem and the earliest sign of redness, photophobia, please come in so we can start the treatment as soon as possible. Thank you for your patient listening.
Thank you, Dr. Ashmita. We'll have the discussion soon as Professor Namrata ma'am has some other session to catch up. So let's listen to her.
Sorry about this. What happened? So I would be talking to you about a new frontier which is unleashed, and this is the biosynthetic cornea which we are working on. Now if we look at the figures, we know that the common cause of blindness in our country, the first common cause is cataract, followed by corneal opacity, and the major cause of blindness in the population 0 to 50 years is corneal opacity. So in the younger age group, it is corneal opacity which is the commonest cause of blindness. Now if we look at cases of keratoconus, pellucid marginal degeneration, keratoglobus, etc., when we do suturing, we actually have to do a very complex suturing because you have to suture it right up to the periphery there and take it into the peripheral tunnel and then suture it. So, and if we look at the figures of collection versus transplantation, there's a huge disparity. The requirement is 2 lakh, collection is 52,000 and transplants are 25,000, and to this we add 50,000 cases every year. In the COVID era, this dropped down. So there is a need for a biosynthetic cornea, which is there is a need for the biosynthetic cornea, which is nothing which we have manufactured with our Swedish collaborators. And in this is just a case to show that this is a case of keratoconus in which a pocket is created, and after creating the pocket, all you need to do is just take out the biosynthetic cornea from the bottle. This is made up of collagen type 4 and from a recombinant technology, and then just place it intrastromally inside. And after placing it intrastromally inside, the bandage contact lens is then placed over it. And if we see, this biosynthetic cornea is sandwiched in the native cornea. Now this is the second case where keratoconus with pellucid and cataract was present. And again, like I said, the peripheral suturing becomes a little difficult in these cases. So if we can do sutureless, which we can in these cases with the help of the femtosecond laser, again the pocket is created and the pocket goes right up to the periphery there. And after creating a pocket, again this pocket is opened up a little bit, and the biosynthetic cornea is again then placed inside. And after placing it inside, a bandage contact lens is put. Now this case also had cataract, so 3 months down the line we also did cataract surgery, and the cornea still remains quite clear, and there is no problem at all. In this case, if we look at the post-op picture, the vision improved to 612, and subsequently the anterior segment OCT also showed the tectonic stability, and this is the astigmatism which dropped down from almost 80 diopters to 50 diopters. In cases where there is opacity, one can do the recipient part with the help of the microkeratome, with which the cornea is split so that you come to an area which is relatively clear. And this is the synthetic cornea again, which is placed and which is glued to the surface with the help of the fibrin glue. And then subsequently a bandage contact lens is then again placed on it. And this is how it looks in the post-operative period. So what does the biosynthetic cornea do? You don't need anything for that, in the sense that you don't need an eye bank, you don't need the retrieval of the donor corneas, the media, or the eye bank facility, and it is not dependent on human donation. There is no rejection or failure, no suture related problems, and if there is a problem, then it does not preclude a human graft transplant if required. So this is the advantage of the this was yet another case of post-LASIK ectasia, where biosynthetic cornea was used to sandwich in the ectatic cornea. And here the keratometry dropped from 89 diopters to 50.4 diopters, with the pachymetry which increased from 241 to 581 diopters. Again, you can see the confoscan pictures of the nerves and the endothelial cells through it. And this paper was published in Nature Biotechnology, which has an impact factor of 68.1. So what we have looked at is the stromal construct, but I think when we grow cells in this stromal construct, then you can have a complete corneal construct. And there are a lot of blind children who are waiting to be rehabilitated. And I think the future is going to be that just like we do for intraocular lenses, from the bottle we would just need to take out the biosynthetic cornea and implant this. So thank you very much for your kind attention, and if there are any questions, I would be happy to take them.
What stage of development is this?
So we've had 5 years follow-up in 30 plus eyes. We have already done it. In the beginning we were a little slow because we wanted to see the results, but now I think we are there. As far as the intrastromal implantation and as far as the you can say lamellar keratoplasty is concerned, it is there. It can be done only in selected cases as of now, but growing endothelium cells on this is a little difficult, which we are working on in our labs. I think it should take a couple of years to sort that out also.
Do you
Huh? So diseases are pellucid marginal degeneration, keratoconus, even in cases of healed keratitis, if they are anterior, there also you can use it. As of now, it is free of charge if anybody wants to try it, because our project is going on. So we can recruit you in the project and then maybe give them to be tried free of cost. There's no charge for it as of now. But I'm sure once it gets commercialized, they are going to put a price to it. Suturing is a little difficult because they cheese wire.
Interesting, ma'am. And with the advent of femtosecond lasers, high precision knives, all these are very much possible also.
Yeah, you can make a proper pocket and proper depth also. No?
Yeah.
Okay, now
Thank you.
you yourself going to present?
Meanwhile, we have not taken the discussion for the first, the viral keratitis.
तो फिर मैं भी judge हूँ यार इसमें.
As science is advancing, even management of herpetic keratitis will also take a change in the near future, I hope. Right now, HDS has only defined certain treatment guidelines, but I'm also a part of one of the vaccine development teams who work for therapeutic and prophylactic vaccines against HSV1 and HSV2 keratitis. We do have certain candidates, and shortly we'll be starting with the clinical research. The preclinicals are completed, clinical research by probably by June or July 2023.
Sir, just about the last presentation which we forgot to discuss. So one of the very important differential for HSV is stromal keratitis is microsporidia. So wanted to ask specifically you, how do you differentiate? I'm still not very clinically feel very comfortable to differentiate chronic microsporidia, stromal microsporidia from viral stromal keratitis.
Even I don't have the huge experience in this area because microsporidium is, seems to be limited to some parts of our country where more cases has been identified, especially the coastal belt of Odisha, and most cases have come from LB Prasad Bhubaneswar, in fact, and they are the one who described this, stromal involvement of a microsporidium in these cases. I think the difference, if whatever I have seen few cases there in LB Prasad Bhubaneswar, I was there for a 1 week last year. And actually the presentation's little different. These are cases which ultimately, may have started as the epithelial disease to begin with. and suddenly goes to a stromal area, and most cases have been a normal people, like even for a herpetic disease, they are normal people without immunocompromised situation. The stromal melt is much faster here, and the involvement is much deeper, and the surrounding cornea still looks healthy. This area of concern is the area where the stromal involvement is happening in these patients, and the onset is also rapid, and the intervention has to be too rapid also, otherwise you lose the cornea very fast in these cases. And actually the use of steroid is again a concern here also in these cases. Like in a herpetic, we know that steroid will help in those cases. Here we are not sure if steroid is going to help. Sometimes it goes other way around in these cases also. Though I don't have a huge experience, if you, Lionel has some experience that.
Here in Bihar we see a lot of epithelial microsporidal keratitis, but stromal
it's quite rare. In fact, actually they have termed the new terminology for this, this disease. So may not be truly epithelium going to stromal, it may be directly, sometimes they come as a stromal disease only.
That is, yes.
Microsporidal, I do agree with early signs of viral keratitis, it may mimic, but very classical viral signs, clinical pictures that include typical epithelial pattern, stromal necrosis in the later days, and absent corneal sensation. PCR is always there.
The one which presents like a disciform keratitis, sir, not with a epithelial involvement. I mean, those are the like pure stromal and pure stromal viral versus microsporidal. That is also one.
There is a challenge. There is a challenge in that. But unfortunately, we don't have too many microsporidal keratitis in our place.
Variety, that's very difficult to differentiate. But you need to have a little more clinical suspicion in areas like this. And there also the medical treatment fails in a microsporidium. So you have to go for early surgery in these patients. If you go for early dark, you can salvage the eye. If you just continue, anti-infective and steroid, the cornea melts out totally within a few days. So that is one learning people have given us. If you suspect the microsporidium necrotizing stromal keratitis, the surgery has to be done immediately.
And just to add, not about the microsporidia, but also the diagnostics in herpes simplex, our team is working with the new system. We call it ABVIC. We have cleared MHRA, and also we have reached the fast track status of FDA. So that is very specific as PCR and as easy as a serology. So that would also
just for viral, sir, or for any
for HSV 1 and 2.
HSV. Okay, let's go to the next talk. Seems a very interesting talk. Lionel, you can start your talk.
I thank our Honorable Chairman, Professor Titial sir, and I also thank AIOS and the audience here, my friends, for giving me this opportunity to present something which is totally synthetic. Namrata ma'am was telling some biosynthetic, but this is completely synthetic because endothelium, as we know, doesn't have a propensity to regenerate by its own. There are some efforts going on to work on regenerative therapies, bring up stem cells in endothelial dysfunctions, but my talk today will be confined to a novel synthetic corneal endothelial substitute, I would call, in cases of chronic corneal edema. It's a phase 2 safety evaluation study, and I'll be presenting the interim reports. I do not have any financial interest, however the product is from an Israel company. As we know, corneal blindness due to endothelial dysfunctions vary from 3.8 to 11%. 1 to 2% are pseudophakic corneal edemas, and risk of graft rejection after keratoplasty can go as high as 30 to 40%. And endothelial transplant, it is the various reports are given between 2 and 10% of graft failure prevalence. So in country like ours, it is 1 out of 70 needed corneas we get for transplants. So this justifies the role for an endothelial substitute which forms an impermeable barrier to fluid and reduce the passive diffusion of fluid into the corneal stroma, thereby keep the cornea in a relative dehydrated state. So the purpose is to evaluate the safety of implanting a synthetic corneal endothelial substitute in cases of chronic corneal edema, of course in selected cases due to endothelial dysfunctions. This is an open label phase 2 clinical evaluation, and surgical procedure I will show you. Outcomes, the primary outcome is the corneal thickness, central corneal thickness. Of course the secondary outcome is also pain and visual analog scale. So this is how, this is a pseudophakic corneal edema. The loose epithelium is removed. The central 7 millimeter I mark. A careful decimeter excess of the central 7 millimeter is made in a very conventional way, just like as we do for any endothelial keratoplasties. After having removed, I'm sorry, I'll play again. This particular material is completely a synthetic material, and it is just like IOLs. It is similar to a Rainer foldable IOL. That's what the company says. I'm sorry for the length of the video. It looks quite long, but I have no option of advancing the video. I'm sorry. It prevents diffusion of fluid from the aqueous. It's an acrylic material similar to that of Rainer intraocular lenses. The thickness? The thickness is 25 microns. As like any other endothelial keratoplasty, we make inferior peripheral iridotomy, and this is how the material is. Yeah, just like a contact lens, but much thinner. And being a synthetic substitute, we don't have to worry about damaging the endothelial surface. We can just meddle the implant in whatever way we want. Once when it is placed in the center, I use a gas bubble and then make it well centered within the 7 millimeter zone. The overall diameter is 6 millimeter, and I use C3F8 gas to fix. Meanwhile, I also give one primary suture through the synthetic implant to help them stay in place for the initial few months, maybe weeks or months. And finally, fill the chamber with 80% C3F8 gas. And we also have an F mark to find the correct orientation of the implant. So this is a representative case example, a pre-op day 1, day 7, day 14, months 1, 2, 3, 4, and also till month 6. We have follow-up data with central zone remaining very clear. The visual acuity gains in our series of 12 cases, baseline was on an average, the mean was 10 characters, ETDRS characters, which improved and stabilized over 55 characters over time. The corneal edema, it was 750 microns in the baseline, and now it is very much stable at 495 or 500 by month 6. It's another case example which shows the device is well attached over a period of time. We also have one patient who died in between due to some other cardiac illness, but we could retrieve the cornea, and we did subsequent histopathological analysis, and we found very good fibrous adhesion along the edge of the implant. So it was tough. It was not possible to even remove the implant even after death. Rebubbling, yes, we had some of the cases. We had frequent rebubbling in one of the cases 3 times, and if the implant is stuck there for more than a month, generally it doesn't detach. Early stages there were rebubbling requirements. To conclude, synthetic endothelial substitute improved vision, reduced corneal edema, and also it reduced pain scores, pain analog scale, and they were not associated with toxicities until month 6, and we are still in further follow-up of these cases. We look forward to having the global reports come up in 1 or 2 months. So this could be a good substitute for endothelial keratoplasties, at least in selected cases. Thank you.
Thank you. Very nice presentation. I think few points which you can highlight. One is because this is definitely a synthetic material. So attachment is the concern you rightly pointed out. You may require multiple rebubbling, and instead of one suture, if you put 2 sutures where you have equal support from either side, may decrease the requirement in these cases. And I think we would like to know how this synthetic material sustain the corneal function, because it doesn't have an endothelial pump. So how does it clears the cornea, which is people would like to know that.
All right, sir. I'll take up the first question. It is having one suture. Dr. Offer, who have brought up this technology, he, in his initial cases, he didn't have any sutures, but the implant can drop into the AC, and it's being 25 microns, it's very difficult to find it out also. So in order to facilitate the implant in place, not in place, the suture is meant only to facilitate resurgery for rebubbling. So it was advised that we use one single suture at 12 o'clock so that the device doesn't go down. But it's a good idea to have multiple sutures also till a good fibrosis at the edges happen. Number 2, as we know, yes, nothing can replace endothelium. We all know it has got active pump mechanism which pushes fluid outside the cornea. But this one is aimed towards acting as a barrier towards the passive diffusion. So many of the cases, if we see, the central 6 millimeter of the implant zone remains clear. The rest of the portion will still be edematous in some of the cases. So this acts only as a barrier. It doesn't. It cannot also replace endothelium. Yes, because of the curvature. But it really doesn't matter much. But the device is made in such a way that it follows the base curve of the posterior cornea.
I think other things which are important is, one is the refractive index of this substance. Though it is a thin one, should have, almost similar to a cornea, so that it doesn't cause another refractive this thing. And other thing is, as I remember, Mark Terry had initially for a DSEC, he used to scratch the periphery and thinking that DSEC lenticle will get attached with the fibrosis. If this is the concept here also, fibrosis of periphery, so you can scratch and get a fibrosis done faster.
Here we want the opposite. we want the peripheral endothelium to be intact
Ah.
because we want some endothelial cells to work in the periphery for the peripheral cornea to be remain.
No, just where you're scoring, there is to have a stromal scoring also.
Yeah.
So
yeah.
that you have a
Yeah.
better attachment of a lenticule, DSEC, which was not actually required in a normal DSEC surgery. Here I think that may be a one point, where
that can induce fibrosis
yeah,
also.
an early attachment of this synthetic lenticule.
Yes.
But it's a very interesting, I think we need to wait for some more time to get the results.
Yeah.
And a proper case selection is also important in these cases.
Exactly,
I think,
sir.
early cases would do better, like you do for a DSO or a DVEC. So similarly, this will also be very chronic cases may not be of very great help.
Correct.
Yeah.
And also viral cases,
Yeah.
we shouldn't touch. And we are also waiting for long-term reports because we don't know a synthetic material, does it cause any stromal lysis for the thinning of cornea. All those we don't know for the long term. All that we have is 8-9 months data, the longest follow-up in our series, and most have crossed 6 months.
Thank you,
Thank you, sir.
Leonel. I think I remember, we had Professor Daljit Singh from Amritsar. Once he had described the treatment for corneal edema by making a full thickness multiple punctures from epithelium to endothelium. And he described these cornea subsequently got clear. So there are various tricks people have played, but ultimately I think, as you rightly said, nothing better than replacing the endothelium. Like this case also, if you have access to a good endothelium, why not to use that? But this is also a very good option. I've read this earlier also. We are waiting for long-term results to come in this area also. Okay.
Rejections?
Yeah, there won't be any rejections. Sir. Let's go to the next speaker who's on the line. Anybody here? Yeah, please come. Divya Kumari. The contact lens is basically a refractive lens. It has various powers you can put into that to correct the refractive from the anterior part of this thing. And contact lenses are never so thin. They are a little thicker than this, and this 25 micron is actually very, very thin and extremely thin. Would be difficult to manipulate inside. It is like and it is absolutely clear. And I don't know how people will see, especially in the Indian eyes, maybe it's still visible because we have a brown iris. You might be able to see, but in a Western eye, it will be difficult to pick up where it is, There, I think, like devices like we have intraop OCT that might help in these cases to really see where is the graft, how well it is attached towards the end of surgery. Because if you see, like we have been working with the AIOCT for last, 6-7 years. So all cornea surgeries have become very, very, visible on the table. DSEC, DMEC, like this also. If you have a OCT, you know that where exactly graft is, which area you have a pocket. So you can do scanning and do a counter pressure technique to take out the fluid from there, or you just reorient the graft in a manner. You may have a peripheral fold sometimes. So those can be seen. Okay, Dr. Divya, please.
Good afternoon, everyone. My topic is restoring ocular integrity of perforated corneal ulcer using host tissues derived from keratoplasty during COVID-19 pandemic. Aim of the study was to report initial clinical outcomes of therapeutic PK for perforated corneal ulcers using host corneal button. Therapeutic penetrating keratoplasty is a surgical procedure to restore globe integrity or to resolve infectious or inflammatory keratitis non-responsive to medical treatment. COVID-19 pandemic caused unprecedented crisis to corneal surgeons. There was an acute imbalance of demand and supply of tissues. We report 2 cases that required therapeutic PK and were managed successfully by graft derived from host tissues of patients undergoing optical PK for PBK. Case 1, 26-year-old female, history of trauma with wooden stick for 6 days duration. Patient had a complaint of redness, discharge and decreased vision in right eye and was previously treated with eye ointment, itraconazole, moxifloxacin, tobramycin, atropine ointment with no symptomatic relief. Systemically, she was okay. Ocular examination, visual acuity was hand movement close to face with PR accurate in all quadrants, and cornea had a perforated corneal ulcer of greatest diameter of 5.1 into 4.2 mm with 0.5 mm diffuse stromal infiltrates in surrounding corneal stroma. Anterior chamber was shallow inferiorly and fundus was anechoic on ultrasonography. Preoperatively, all the viral markers were non-reactive. KOH showed filamentous septate fungi and seborrheic agar has Aspergillus species. Patient was started on eye drop natamycin, homatropin, moxifloxacin and tablet ketoconazole, and therapeutic penetrating keratoplasty with intracameral injection of voriconazole was performed using glycerine preserved non-vascularized host tissue obtained from optical PK of PBK patients. Size of the graft was 7.5 mm. Post-operative day 1, graft clarity was 0 and graft host junction was well opposed. Anterior chamber was formed and patient was maintained on the same medications as advised pre-operatively. Post-operative day 1, graft clarity was 0 and graft host junction was well opposed and anterior chamber was formed. Patient was maintained on same medications as advised pre-operatively. Patient was followed up weekly for 1 month and graft clarity didn't improve. Graft was completely epithelialized at 1 week. There was no recurrence of infection and follow-up of the patient was done through telemedicine services because of COVID. No, at 1 year follow-up, graft was completely opaque with inferior conjunctivalization of the graft and ASOCT was done which was suggestive of thick epithelialized graft with well opposed graft host junction. Optical PK was performed after 1 year. Final visual acuity at 1 month post-operative visit was 636 parts with a phakic correction. The histopathological examination showed stratified squamous non-keratinized 5-layered epithelium. These are the pictures. Second case was 68-year-old female presented to our department in February 2020 with complaints of redness, pain, photophobia and decreased vision in left eye for the duration of 1 month. Left eye vision was PL positive and PR accurate and on cornea had a perforated corneal ulcer of size 4.7 into 4.5 mm with Descemet membrane folds and shallow anterior chamber. Preoperative investigations, viral markers were non-reactive and KOH wet mount showed filamentous septate fungi and SDA had Aspergillus species. Systemically, patient was within normal limit and patient was started on eye drop natamycin, homatropin, moxifloxacin as well as tablet ketoconazole. And same as previous case, therapeutic PK with intracameral injection of voriconazole was performed using glycerol preserved non-vascularized host tissue obtained from optical PK of PBK patient. Size of the graft was 7.5 mm. Post-operative day 1, graft clarity was 1+, graft host junction was well opposed and anterior chamber was formed. AC details were not visible. Patient was maintained on the same medications as pre-operatively and no exudate or hypopyon was noted. Patient was followed up weekly for first 3 weeks. There was no recurrence of infection. Graft was well epithelialized at the end of 1 week. Due to widespread pandemic, he was followed up by telemedicine services. At 1 year follow-up, visual acuity in the left eye was perception to light with projection of rays accurate in all quadrants. Graft clarity was 0 with devascularization at 4 and 5 o'clock positions. ASOCT at 1 year was suggestive of thick epithelialized graft with peripheral anterior synechia superiorly at graft host junction, while peripheral anterior the optical triple procedure was done at 14 months when the donor tissue became available. Patient's final visual acuity was 20/80 at 1 month post PK. These are the pictures. During lockdown, the number of donor corneas collected and thus emergency therapeutic keratoplasty performed decreased significantly. Tissues from other eye banks could not be transported. People started glycerol preserved corneas or scleral patch graft for therapeutic purposes. We anticipated tissue scarcity due to COVID-19 pandemic and promptly preserved 4 host tissues derived from optical PK and glycerol. Tissues were utilized on day 6th and day 8th of their storage respectively because even glycerol preserved corneas were not available to us. Take home message: therapeutic PK using host tissues obtained from recipient of optical PK is a safe and effective option to restore ocular integrity in cases of emergency. During the shortage of fresh or glycerol preserved corneas, optical penetrating keratoplasty is required for visual rehabilitation at later date. Thank you so much.
Thank you, Dr. Dibya. I think during COVID, we did have a lot of problems, not only for our human health, for a corneal transplant surgery also. Eye banking was totally, stalled, and tissues were not available. I think we had to resort to various ways to, treat these ulcer patients, especially ulcer patients. And this is a good concept, using the corneas from the, patients. And some eye banks did have, glycerin preserved eyes, and those were used. In fact, in the literature, people have used glycerin preserved eyes, to save the eyes with infection. and replace these glycerin preserved eyes in the next within 1 or 2 weeks with a good optical tissue. And that also prevented infection to spread and reoccurrence of infection also. Here the basic purpose of infection control and tectonic support achieved very nicely, and both the cases after second transplantation had a good results. Even for a small perforation, people have used Tennant's patch from a patient's own tissue to plug that, and that worked wonderfully well in a small perforation also. Thank you, Divya. Any comments?
Yes, sir. It is just like practicing spending discipline when we get very less salary. Something similar to that. It's a nice concept.
Very nice. Okay, is Dr. Arvind here? Okay. No. I think that ends the session here. And any questions we would definitely like to answer. We have 2 or 3 young people sitting here.
So a situation like that comes again, would it be, I wouldn't say wiser, but more prudent to withhold all the optical keratoplasties and save emergencies?
No, that's a good thinking. Like we do get, eye banks, we do get tissues which are not suitable optically. And they should not be thrown, they should not be discarded, they should be preserved, glycerin preserved can be done, which can be kept for 3 to 6 months. And every 3 to 6 months, you replace that tissue with the new glycerin preserved tissues. So any good eye bank will have, at least 50 to 100 glycerin preserved tissue like that. So that should be, emergency should be able to redistribute amongst the concerned areas. Today, the basic problem of eye banking and tissue retrieval is in some of the states it's very difficult to take the tissue or send the tissue out of the state. We don't have a good centralized distribution scheme. So that is a need of country today, where you can utilize the tissue which is available in one corner of a country to other corner. That will only happen once we have a uniform registry for people requiring corneal transplantation, and uniform registry of a tissue which has been retrieved, and they are distributed accordingly. I'm pretty sure if that happens, India will not have a patient waiting for keratoplasty, because some areas, some cities, there's excess tissue. There's some cities, some places where there are excess patients. So this is only because you don't have a good distribution scheme. If that happens, I'm pretty sure corneal transplantation will not be a major problem for the country. And I don't really think the synthetic artificial thing will be required, because majority of cases can be saved by these type of transplantation. Yes, for a futuristic point of view, some sort of a synthetic cornea would be devised, because that should have like a normal cornea. It should have epithelium to endothelium. If that happens, yes, why not? Without any rejection.
And PK and TPK will never vanish.
That will be there. That will be there. Okay. Thank you for being with us.
Thank you.
Partner, sir.